And just to get started, I would like to acknowledge that the University of Melbourne sits on the lands of the Wurundjeri people of the Kulin Nation, and that we acknowledge and pay respect to their elders past, present and emerging. Now, we are videoing this meeting because we'd like to be able to share it with other prospective participants on our Making Waves platform. So if you do not wish to be filmed, then if I can just remind you at this stage, switch off your camera so that you're not identifiable. Terrific. Well, I think what we'll do to get started is start with a case, because I know that some of you may not have any experience in ultrasound, some of you will. But I want to show you a case just to get you thinking. So the first thing I'm going to do is just share my screen. And I'm going to use our learning portal and actually show you a case from our course, or at least parts of it. Now, I want you to imagine that there's an elderly lady coming through who's small. She's fractured her hip. She's had previous hip surgery, but she needs really a total hip replacement. And this is emergency surgery. She's got no known past history of much, but she's from a nursing home and really is quite limited in exertion. And on examination, you hear a systolic murmur, which has not been heard before, but she has a normal blood pressure. Now, I want you to picture yourself where you work right now. You could be the ED physician who's the first doctor to see this patient when they hit the hospital. Or you might be the general med physician or the orthogeriatrician, whose job it is to help manage these patients in the perioperative setting. You might be the anaesthetist who's tasked with taking this patient to surgery, or even a high dependency or intensive care doctor who might get involved. So each of you will have a different perspective and a different part of this patient's journey. So what I want you to think about is what you see, how will that influence how you manage this patient? So I'm going to go to a video and play it. I'm not going to comment on what the findings are. I want you to look at it and see if you can work it out. And just an aside, if anyone's got their mics on, if you wouldn't mind just switching them off, that would be great. And I'm going to stop the video there. Now, there's one very important finding and a few extra ones. So if any of you would like to put in chat, tell me what the diagnosis is. So I'm going to see if any words come up, any words of wisdom. Whatever you think it was that would really fundamentally change what you do, stick it in chat. Well, I'm not sure if you all noticed it, but this patient has severe aortic stenosis. And you could pick this in about 10 seconds just with pattern recognition alone. So I'm just going to go back and show you the absolute key finding. And I'll just zoom it up a bit, and I'm going to stop it here. If you look at the aortic valve, which is here, it's bright, it's thick, and barely opens. And we call this the heart bone because it looks like a bone with a little fracture line in it because those leaflets are just not moving. Now, orthopedic colleagues had different take on this. They kind of put some screws and plates and make sure those leaflets will never move again. But for us, it has profound implications in how you'll manage this patient all the way from the ED to discharge and beyond. And this is an example of how point-of-care ultrasound added to your physical examination can make a vast difference to your practice. So what I'm going to do now is have a chat to my good colleague, Lindsay, because Lindsay is quite possibly one of the most qualified emergency doctors in ultrasound, certainly one of the most passionate, and has been doing it for a long time. So Lindsay, can I ask you, how did you get started in clinical ultrasound in the ED? What was your motivation?
I think the main motivation comes from a few different background experiences, and then realising that this is going to be something that we need to use going forward, both for our own benefit and the patient's benefits, but also as leaders in this potentially around the world. The story of my initial use of this was being partly self-taught in using it in the Rwandan Civil War just for basic peri-labour obstetric scanning. And then I did come across a world leader of ultrasound, a guy called Michael Heller, who wrote a book around the turn of the century and was very influenced by that. And then I did a whole stack of short courses, which I know a lot of people do nowadays over the next 10 years or so. But from around about 2010 onwards, I decided to do extensive training so as that I would be able to know it well enough to be able to teach other people, and that was part of the aim. And the end result of all that is that, as Colin said, I've now got quite a few national and international qualifications, which have taken quite a bit of work, but also mean that I've been able to be exposed to a lot of different ways of teaching it and looking at other ways that other people around the world have taught it over the years as well.
So Lindsay, how has this impacted your daily practice? Like, how do you use ultrasound in the ED now?
I don't want a party. No, I don't want a party. Not this year, not next year, not any year.
So most of the time I use it in the way that I would use it as a diagnostic tool, but I also use it as an alternative to comprehensive ultrasound. So I might be seeing a patient myself, or I might be asked to use ultrasound by somebody else, or I might have to intervene because I can see that it's going to be necessary looking around the emergency department. And so that could be any combination of lung ultrasound, focused echocardiography, DVT scanning, abdominal scanning, early pregnancy, vascular access for difficult or shock patients or paediatric patients, all manner of ultrasound guided procedures, including drainages of fluid collections, diagnostic joint taps, and even pericardial taps. A lot of these are patients that need a diagnosis to improve their patient flow. That's a big deal in emergency medicine now. It's not just about how accurate we are in being able to know what's going on. It's about actually helping people move through the chaos of the current state of the health systems. But a lot of the time it's also to improve their actual quality of care and their interaction with the health service, so as it decreases pain, unnecessary tests, those sorts of things. In some ways, we are actually replacing comprehensive ultrasound, even though that's seen as a controversial statement. If comprehensive ultrasound is unavailable when we're doing these limited focus studies, then they may well be required, or some other imaging afterwards to confirm it, or as part of their ongoing treatment. But at that point in time, you could argue that we are actually doing things that replace those services if they're not actually available.
That's terrific. Thanks, Lindsay. In fact, another colleague of mine who's a ED physician and did a PhD with me, he says it's his left hand. It's just the probe is fused to his hand because he uses it so often. And in fact, we've seen the same in anesthesia, we see the same in ICU, we see the same emerging with our internal medicine colleagues, because the data is very clear. 50% of the time, you're going to be wrong if you rely on history and examination alone. You might as well flip a coin. And even if you're a relative novice, you'll probably push up your accuracy to 80 to 90%. So you could argue that to not do an ultrasound, you're going to miss 50%. To do one, you might miss 10%. And I think that has some really important implications for patients going forward. So look, we all know that when you start something, Lindsay, is never easy, never an easy path. So what were some of the major challenges you faced in incorporating ultrasound into your practice? And what sort of tips can you share for our audience to overcome them?
I think one of the first tips is you've got to have access to a machine, and that might sound like a simple thing, but you might have to make it a goal that you or other doctors or other clinicians need to motivate the health service to get a decent, good quality machine that suits your scope of practice. On the other hand, there's a lot of handheld machines now which are coming onto the market, which are excellent for entry-level development of skills. I still think that in Australia, and certainly in a lot of other parts of the world, we are still being seen as non-radiologists or non-specialists who are adopting a skill that we won't ever know well enough, or won't be able to be trained to a standard that's going to suit patient outcomes and be useful. And I think we've got to move on from that and not take that personally anymore. There's now good guidelines to support national standards, international standards for training. There's no doubt, as Colin has just said, that there's evidence base behind our practice and its utility. And I think if you have those low moments when you do feel like you're doing something strange, it's really important to build a network of mentors and have people who perhaps have moved on a bit from that and can guide you and support you as you're developing your skills.
Thanks, Lindsay. That's terrific. Now, if any of you guys have questions, we will stop and pause and deliberately ask you a question. You can always put your hand up or use the raise hand icon, but you can also put some questions in the chat, and then we'll be able to track those and answer them. Fantastic. I'm just giving you a little pause minute if you want to put any questions in the chat.
I was wondering, Colin, I've reflected on where I am at. You started this at least as early as I did, if not even earlier. I was wondering if you could comment on some of your experiences acquiring particularly advanced echocardiography skills over the years.
Yeah, sure. Actually, I started doing ultrasound in 1995. So I'm more than 25 years now. But you know something, the penny dropped for me when I was doing a coronary care rotation. And we all have penny drop moments, and I'm sure that in your own journey you'll find this. But I was sitting there with a patient not doing well, that probably had a heart attack, and the cardiologist, a lovely guy, said, well, what would you do next, Colin? I said, well, being an anaesthetist, right, I'll put a Swan-Ganz catheter in, I'll check his cardiac output, maybe start some inotropes. He said, no. Picks up the telephone, calls the echo tech, who comes around with a massive machine in those days, puts the probe on, and that whole anterior wall was not moving and heart was dilated. Instantly, I knew the problem. I knew what we had to do, and the penny dropped. And I was determined that we'd introduce this into anesthesia because I know it would change what we do. Now, of course, when we started, it was mostly toe for cardiac surgery, and I'm a cardiac anaesthetist, so you had to learn a high level. You had to be diagnostic level. And so it had a huge tumultuous journey amongst us to all upskill rapidly. And in fact, that was the impetus for the University of Melbourne award courses, because we had to do it in a way that we could get people on board quickly, uniformly, and at a high standard. And of course, we're going to talk a little bit later, but boy, it's been a wild journey since then. from what was really perceived as, you know, a bit freaky and out there to very much mainstream. And that's where we are today. I do see a question here. What is the current relationship with radiology like re the use of ultrasound? Unfortunately, we cannot escape politics or sandpits. And although we all try to say that medicine should not be siloed, the reality is it is, particularly if there's a dollar involved. So I think it very much depends where you are and what relationships you've built. When I go back 20 years ago, it was a sandpit fight. You know, you had to basically struggle to get there. I think now most of the other specialties not only realize how important this is, but are actively starting to encourage it. So the cardiologists, they walk around with a handheld machine now and look for fluid on the lungs as a mark of heart failure. They don't need a formal echo every time. And our radiologists too, if they had to service every single request we did, you would never, ever get the service. And I think what people have started to really realize across all specialties is that there's a vast difference between using the ultrasound to assist your clinical evaluation by the patient's bedside in real time versus producing a formal report for others to act on. I think that's a big differentiator. When there's doubt, we always refer to the big labs to get confirmation. But I reckon in my practice, 95% of the time, I have enough information to make an important decision. Now, I'd be interested, Lindsay, do you have a similar sort of hit rate in terms of knowing what to do with the patient?
Yeah, I think certainly now it's at the level of almost developing orchestra level musical instrument skills for me. But I do remember starting out and having to have a pretty strong black and white view of what question I was trying to answer. And I think that's one of the key lessons, especially when you're starting out, is to mainly stick with answering a specific question with ultrasound that can be answered by the skill set that you have and by the level of training that you have. And then as you go along, you'll develop more and more of those and they'll become a repertoire of skills. But there's a tendency to just look and say, I can answer anything, but I think it's really important to start out answering very specific focused questions.
I agree. What's fascinating is once you learn one ultrasound protocol, if you like, it's very easy to learn more. Like if you learn the heart's the most complex. And in terms of acquiring images, lung is dead easy, DVT estimation is easy. Basic abdominal, but not advanced abdominal, is relatively simple. So there's always a phase where it's going to get tricky, and that's for the experts. But mostly, we're not wanting those questions answered. And I'll give you an example in anesthesia. You know, I still have registrars now who will come and say, well, I'm not sure about this patient's fasting status. We should use rapid sequence induction, put a tube in. And this patient may have been adequately fasted. I say, well, how do you know? And then I get out the ultrasound probe and we scan the gastric antrum to see if it's full or empty. And I say, now you know if it's empty or full. Now you can be rational about how you decide whether you're going to use a rapid sequence, put a tube in, or whether you're happy with some other form of anesthesia. It takes me about 30 seconds to make that decision. What we might do is just open up the floor for questions at this stage. So feel free to wave your hand or use the icon and switch off your mic and ask us the question. Don't be shy. This is a good opportunity. All right, I'm not seeing any questions raised yet, so I think we might go on and look at another case. So Lindsay, which case did you want to have a look at next?
I think you've got them there ready to go. There's somebody who's post-operatively short of breath. Now, again, this is a little bit of an operative sort of focus, but on the other hand, the shortness of breath is a very common presentation, whether it's in primary healthcare, on the ward, in the emergency department, in remote healthcare settings. And this is partly to display the use of lung ultrasound, that it might actually be able to definitively answer the question. And you'll see the clinical stem there in this particular scenario, that somebody's had an operation, and that after the operation, they're not just short of breath, but they're actually in distress. They've got some decreased blood pressure, and there's concern as to what this could be. So there isn't definite signs as to what's going on by examining the patient, and there often isn't in these particular scenarios, but we've got a few video clips that I just wanted to show here. So this is the right anterior lung, showing the intercostal muscles between a couple of ribs, and that's the pleura moving. On the left-hand side, you can't see the pleura moving, it's completely immobile. So already at the start, you've got suggestion that there's no lung moving on the left-hand side. On the lateral side, up near the axilla, it's still not moving. When you go down into the sort of posterolateral region, you can see the pleura sliding again now. So that means that there is lung contact down there. And here we've gone from that region up into the sort of mid-axillary line. And so now you can actually see that there's a zone there where there's a point where there is lung contact, and then there's another point just adjacent to it where there actually isn't any lung sliding. That's an M-mode representation of the same thing. So you can see a stratosphere sign on the right-hand side of the screen, alternating with a bit of what's called a seashore sign, which is that grainy appearance underneath the pleura. So in the time that it's taken for us to describe these pictures, you have definitive evidence of a pneumothorax. You've got an idea about where the lung actually is in contact with the chest wall. And so you've got an idea about how big this is as well. And this combination of lack of lung sliding on one side and a place where there's a transition between lung moving and not moving, which is called a lung point, is close enough to 100% specific for a pneumothorax. And this person may well need a rapid decompression and a thoracocentesis and a drain and all sorts of stuff. And those things can be implemented confidently in the absence of a chest X-ray, even when the clinical exam isn't definitive.
That's terrific.
Lung's a very powerful tool, and it's, as long as you're sticking to some of these pattern recognitions and understand the images, even though they don't look very anatomical, it's actually a very, very powerful tool.
In fact, if you had to start with one area to practice on, lung is the easiest. And the reason is it's very easy to acquire the images. You just plonk the probe on the chest and slide it up and down. But there are only 6 major pathologies you have to learn. And the fascinating thing about lung ultrasound is that it's all artifact, because air in the lung is ultrasound's enemy. So a normal lung, it's all artifact. But as you get pathology, you get increasing or decreasing airspace, and that allows more ultrasound through, which gives you the images. So for example, a pleural effusion is a black space next to the lung because the fluid transmits. And you might be interested in this, but a chest X-ray will often miss a pleural effusion under 1 litre. It will not be missed with ultrasound. That's terrific. Now, does anyone got any questions about any of this so far? I've got a couple here now. So what's the, do you recommend any ultrasound courses for beginners? I'm a physician based in Victoria. And it's fascinating. I might actually just take you to a different slide now. And that is to talk about the expertise pyramid. So the one thing about even experts once upon a time had to start somewhere. And so getting started at the lowest level to get you familiar and give you basic pattern recognition is something we should be doing for everyone. That's our aim, is every single doctor should be doing that level of training. And that is short courses, simulator programs, so forth that we have, and we have those at the university. But realistically, to go beyond that, you have to build knowledge as well as hand skills. And today we're mostly going to talk about the award course structure. So we built this triangular expertise pyramid to match our courses. The graduate certificate is currently the smallest offering, which is 4 subjects and takes either 6 months part-time or a year, sorry, full-time or a year part-time. It's all online, so it can fit in with your practice. And effectively, you're going to get to the point of being a good basic sonographer in the point of care ultrasound. But for people who want to go more, we've got a diploma. And for those who really want to stretch themselves, we've got a master's program. So the whole idea is that the more expert you come, you will continue to do levels. So in answer to the question, that's what we'd be recommending. Maybe you do a short course somewhere to get the flavor, to get excited, but realistically, you're going to do a graduate certificate to follow that. All of these courses are available to anyone as a doctor. So if you're a GP, absolutely. Okay. In fact, particularly at our lower level, our certificate course, anyone who's got a health science degree can do it, because we do believe that not only will doctors find this very useful, but in the future we'll be seeing paramedics, allied health staff, physiotherapists, all picking up the probe to help them in their evaluation. What I might do is just move to the next slide and get Lindsay to talk you through the way that we advise people on their subject selection when they choose to do a course with us.
Yeah, thanks, Colin. So it's a busy slide, but if you break it down, as Colin just said, we recommend that you start with the graduate certificate. There's a principal core subject which everybody has to do, which has all sorts of things like physics, how to operate machine, artifacts, understanding how images are generated and the basics of optimizing them and interpreting them. And then it depends a bit upon whether you see yourself going on with a strong focus on echocardiography, or you've got sort of multiple general applications that you're interested in developing. And so there's electives after that. And you'll see that there's some ultrasound guided procedures, some peri-arrest ultrasound, vessels, nerves, lungs, introductions to MSK. We've got a couple of very strong subjects dealing with obstetrics and gynecology for entry-level skills in those domains. There's other more specifically echocardiography focused intermediate level course subjects on Doppler echocardiography and more in-depth understanding of ventricular function, which are requirements for you to go on to the graduate diploma. And as it says there on the side there, there's no question that the body of knowledge you attain by doing the graduate diploma is at a diagnostic level echo. So your knowledge base is at the equivalence of echocardiography and echocardiography technicians. If you want to go further, then we introduce you to all sorts of emerging technologies like 3D and some other advanced technologies. There's a requirement for a master's level graduate to have a strong understanding of research methodology, and particularly as it applies to ultrasound literature. So there's a component of that. And there's some in-depth subject material to do with cardiac abnormalities found in obstetrics conditions. And then there's a whole stack of suggested case studies to read, not suggested, mandatory case studies to read and comment on as you go by, and also a logbook, which we expect people to fill in with about 50 cases that they've actually used in their clinical practice, which is relevant to their scope of practice. So there's a gradual but systematic progression from entry-level skills all the way up to very advanced master's level qualification skills. Thanks
very much, Lindsay. We've got a couple more questions that have come in. So one was about commenting on increased MDO insurance costs for using POCUS. I haven't seen that at all, and I suspect it won't happen. Now, there may be some very specific situations, probably around diagnosing babies and so forth. But for what we're talking about, it's been talked about for 20 years. It has not happened. So I think put that one to bed.
The limited reviews that I've done of the scope of practice and where the scope of practice is going for most of the primary care specialties would imply that this is just seen as scope of practice as long as it's fitting within those guidelines.
Yeah, and there's one that, do they usually try to get an idea of size? I'm not quite sure what that's referring to, but if it's the pneumothorax case, then basically if you've got a touch point around the mid-axilla, that's a significant pneumothorax. That's a big one.
Yeah,
and
it's moderate to large.
And in this scenario where you had hypertension, you would be presuming tension pneumothorax until proven otherwise. The other questions, I'm just reading through them now. I'm an ex-ICU trainee, now a fellow of ACRRM. So therefore, you will use ultrasound extensively in your practice, which is great. You've done the grade cert. How much would the diploma benefit me for day-to-day practice? So it's interesting, and also about regional anaesthesia. So how you use ultrasound in your scope of practice is going to be up to you. But as an example, we have a colleague, friend who's does a lot of country rotations managing the ED. He's a GP, but effectively he's working as a rural GP. And every time he comes back, he's got a dozen stories of how ultrasound helped. Whether it's he diagnosed a heart failure, he saw something on the heart, he just diagnosed a fracture in a child because he put the hand in the water bath, put the ultrasound and could see a black line crossing the cortex. He looked at a knee and said, well, this is probably a septic arthritis, etc., etc. There are so many stories that come out because once you get using it, you use it all the time. Now, with the diploma, it's very much taking the next level in transthoracic and toe. In other words, an echocardiography. So if you wish to upskill in echocardiography, the diploma will be very useful to you. You can, however, if you don't want to go that far, you can add subjects. You can study individual subjects. So, for example, if you didn't do the obstetrics and gynecology one, you could just study that separately and upskill yourself that way. So, Lindsay, you might want to talk about this one. How do we achieve the practical component of the online course?
So I think we just want to make it clear that everybody who's doing these courses needs to still find a mentor, somebody in their workplace, a supervisor who can guide them and give them some feedback. And we strongly recommend that people keep a logbook of the scans that they do and have some reflective adult learning where they compare it to a gold standard or clinical outcome. That concept is now gradually being worked into national and international guidelines, and our courses increasingly reflect descriptors about how to actually go about that. We can't actually supervise you directly because the workforce and the logistics involved in that are huge, but we can support people in describing the processes to achieve that. And as our courses get revised and updated, describing exactly what those guidelines are and how to go about satisfying them are increasingly going to be content that we'll actually be getting people to read about and actually even be asked questions about.
Terrific. And the courses start. So the next intake is very soon. It's actually like next week.
Yeah.
So you can still apply and get onto the course for this semester. But the courses are run twice a year. In other words, the start of each semester. The next intake would start at the end of July, early August, depending on, I can't remember exactly when the university semester starts for semester 2. We can take people up until the end of March. After that, we cannot. But we always advise people, if you are coming in a few weeks late, just remember you've got less time to study. So that's a personal decision. There's also a question around which entry-level ultrasound. My advice is always to get the best one you can afford. Okay, so that's one piece of advice. The second piece is, if you're going to have this attached to you as your personal ultrasound, think of one that's easy to do that. So you've got, for example, the Sonosite IVIS has probably got the best transthoracic scanning of all the portable ultrasounds. By far the most convenient is the Butterfly because it sits in your pocket. You just plug it into your phone. And it's potentially multi-probe use for a single probe. The design is different. So I can't give you a strong recommendation because it partly depends on your price point and also what your key focus is going to be. But any of those is going to be better than none of those because you've got it on your person. You don't have to go looking for a machine. You pull it out of your pocket or your bag and start using it. Jazz has just put up some information about the starting of the course, but we can still take applications. Okay, so we don't have the only absolute hard cutoff is the end of March, because that's when the university says no more. And although we beg them, they say no. Are there any other questions coming through? Well, maybe it's time to whet your appetite with another case. Which one would you like to go through, Lindsay?
One that I've got a bit of an interest in is next one's case study 3. So that's just blandly again called respiratory distress. And these are all real cases. This was one that happened a few months ago in the emergency department where I work. And a typical scenario that could present to a primary care setting, could be a remote country hospital, whoever sees these patients first of all, and occasionally these have even been declared on the ward as deteriorations from somebody who's admitted with non-specific shortness of breath awaiting definitive diagnosis. So when we examine them, as you can see, there's some fairly non-specific physical findings, and you've done your lung ultrasound, which shows that in fact, despite the presenting problem being shortness of breath, the lung ultrasound has a normal A-line pattern with lung sliding throughout, which means that essentially there's no explanation for this person's shortness of breath in their lungs at this point in time. And so you decide to have a look at the heart next. This patient was actually in the corridor of the emergency department. It was around about 10 p.m. at night. And the first tests that were done on this patient that actually were diagnostic were these ultrasound images. And as you can see, there is a significant pericardial effusion around the heart, and there are some definitive signs of pericardial tamponade on this bedside ultrasound exam. So there's a bit of collapse of the right ventricular free wall in that last still image, which you can actually sort of make out on the very, in some of the earlier ones, the RV is actually being a bit squashed throughout some of its cardiac cycle. And then this last M mode shows that at the time that the mitral valve is open, which is that little peak about halfway through the image there, which is diastole, the RV free wall at the top of the screen is actually being squashed in. And so diastolic collapse of the RV is one of the most specific signs of pericardial tamponade. So one of the problems with this is that the presentation that we're often trained to think of as pericardial tamponade is hemodynamic collapse, but unfortunately that's a very late sign, and you've really got your work cut out for you to try and get something done at that stage. The most common presenting signs for pericardial tamponade, symptoms and signs, are actually shortness of breath and occasionally syncope. So this woman was discussed with the referral service, and she was stable enough to be transferred and had drainage of this pericardial tamponade a few hours later at our referral hospital. And these images, sometimes we use them via mobile phones. We don't have a PACS, but that's another discussion. But the person who actually took these images has got intermediate level qualifications and has done quite a few of our courses, and was able to describe with confidence why they thought this person had pericardial tamponade, even though, as usually is the case, the people at the other end may be a bit sceptical of our certainty But when you start talking about what it is that you've actually seen, and especially if you send them a couple of images, there's no question that that's what this person has and what they need doing.
And certainly, Lindsay, I mean, I've seen plenty of examples of that brief echo, and you've picked up a dissection, or you've picked up some other major abnormality that needs urgent treatment. Now, let's say, Lindsay, this patient collapsed. Blood pressure is now 60. How are you going to use ultrasound to fix this patient?
Yeah, so this is another thing true to my heart, having done about half a dozen of these in the emergency department. If you go back to that very first video, you'll notice that in the parasternal long axis view, there's a good 1.5 centimetres between the RV free wall and the inside of the chest wall. So the way we now do this as non-cardiologists is that we allow them to sit up, and we use a linear probe and come in between the ribs at the apex of that picture and watch the needle in an in-plane approach come down through the intercostal muscles and into the pericardial space. And you've got a lot of room, you've got time, and it's actually part of a skill set of most ultrasound facile, ultrasound guided proceduralists now to be able to do that. It's very similar to inserting an IV in a long axis. And this is actually the way it's done mostly around the world now, because a lot of these are being drained in emergency departments in developing nations for TB. We see it mainly in association with cancer. But I've drained about half a dozen of these, and I've had to teach other people how to do it. And you can describe that with confidence, that technique, even in registrar teaching, and people get it, that that's the way they're going to be able to tackle it.
And I think it's a general principle. You know, if you think of ultrasound in generic form, we have ultrasound assisted evaluation. That's the diagnostic POCUS, bedside decision making. And the flip side is ultrasound guided procedures. And whether you're using to put a drip in, a central line, a radial artery line, or a femoral arterial line, or a nerve block, or you're going to stick a needle into a space, it's actually the same skill set. Sure, you've got to understand what you're looking at, but whether you're doing an in-plane or an out-of-plane, and the hand skills that go with it are generic. So, you know, I do a lot of vascular access, and I do erectospinal plane blocks. So I'm used to in-plane and out-of-plane needling. If I was faced with this, that would not be an issue for me, because I have the skill set to manipulate that needle under ultrasound. Are there any more questions people would like to put in the chat for us? There must be a few people desperate to ask us questions, so please don't be shy.
While people are typing responses, we did get one question through email from attendees that could not make it tonight. Sure. One of them was around the CPD points and if the courses are eligible for CPD.
That's a good question. Basically, we've gone to a lot of effort to make sure that almost all of the colleges recognise these courses for CPD, and it's worth a lot of points. So I think that's fine. Now, we've got a question from Ian.
Thank you. I'm a radiologist in the UK, and certainly we've seen a lot more of colleagues locally in ED and acute medicine using point of care ultrasound, and certainly historically there have been a lot of usage with cardiologists using echoes. And I guess certainly from practice I've seen in the pandemic recently, I guess when there was less access to things like chest radiography and CT imaging, where I think a lot of that probably caused a lot of other sort of specialist medical colleagues to start using ultrasound perhaps a lot more for bedside assessment. I mean, I think my question is really, where do you think the greatest residual skepticism on the sort of skill set that you have resides? Because I think certainly having seen what many of my local colleagues do, you know, what their skill set is very good, and it's really overcoming those perhaps residual skepticism, which I guess is always like trying to climb a mountain.
Yeah, it's interesting. Thanks for that question, Ian. Who are the greatest skeptics? It's the traditional owners of the land, the radiologists and the cardiologists. still, because they're used to a certain way of doing business. They're used to having technicians who spend 3/4 of an hour doing very fancy scans, and they're used to looking at pictures. It's a rare time that the radiologist or the cardiologist actually is performing the ultrasound by the patient's bedside, making a clinical decision, although that is changing. And I think the world's moved on from that. I mean, this might sound crazy, but years and years ago, when ultrasound-guided regional anaesthesia was controversial, yeah, it was, and it's about 2005 we're talking about, there was a radiologist who gave this opinion piece that said, anaesthetists should be allowed to use ultrasound for regional, but only if directly supervised by a board-certified radiologist. And we all laughed at that, said, haha, great. If we ever saw one, that would be a bonus, but we just got on with it. And I think that's very much the case. The wave has swept. And what the real challenge now is, how do we get enough people to see that this is important to be a regular palliative practice and provide them enough upskilling? Maybe in 10 years' time, that's an unnecessary comment, because so many of our medical schools are teaching it now. And the next generation of doctors will come out already POCUS trained, and it'll be normal for them. I hope that answers your question, Ian. Lindsay, did you have any comments you wanted to make or to add, or Ian?
I would add that there are, I've certainly come across, and again, this is more of a sort of medico-political front now, there are non-clinician medical administrators who struggle to understand this skills applications and its utility and where it's going. And sometimes they struggle to understand, you know, that people can get trained to be effective in this and even teach other people. There are also quite a few traditionalist clinicians within each craft group who haven't adopted this over the years because they've just not bothered, or they've thought that they don't really need it because they've been getting away with it with excellent clinical skills for many, many years. And I respect that. So there's pockets of skepticism that aren't necessarily the other traditional owners of these skills when you look around.
Did you want to add anything more to that, Ian?
Yeah, no, thank you. I think that's very true. I mean, I think that, I guess, whatever skill set an individual has in the clinical environment, it's, you know, very variable, and, you know, each group should use their skills to their optimal. But I think certainly when you have a shortage of skilled practitioners in ultrasound, I guess it's almost a bit like using, say, like an abdominal stethoscope, where you can see inside areas which can't obviously be seen in clinical examination. But if you've got more increased access to it and you've got a lack of practitioners in areas like cardiology or radiology, then it's important that that point of care usage is available, say like in trauma scanning, fast scanning. But yeah, no, thank you.
And in fact, there was a famous cardiologist called Eugene Braunwald, who is well known as the sort of the modern day father of transthoracic echo. And he wrote an opinion piece a couple of years ago saying it's time to add the fifth pillar of clinical evaluation, because, you know, we're all taught about percussion, auscultation, blah, blah. The fifth one is insonation. And it's because it makes such a difference to your ability to get the correct clinical evaluation. And we've done numerous studies at the university, from anesthesia, pre-admission clinics, ED, general med, and routinely about at least 50% of the time you will come up with a new diagnosis, and it will change your management. What the world's lacking, of course, is really large-scale studies to say, well, does that change in management then lead to a change in outcome? But I can share with you that our group is actually just about to start a 2,000 patient RCT looking at that exact question in hip fracture surgery. So it is coming, that sort of data, but certainly we know very sure that you will change your diagnosis and your management about 50% of the time in the sort of more elderly population that you're likely to use ultrasound. Are there any other questions? Feel free to put your hand up if anyone's got a question. I'm just scanning to see. Well, maybe in the absence of questions, and by the way, please feel free to send us an email if you've got any specific questions. Jazz would love to, who's smiling at us now. He's one of our project officers and marketing guru. He'd love to help get some answers back to you. We might finish off with another case. So Lindsay, you let me know what case you'd like to, what one you'd want to show.
It's case study 4. So it might seem that we're having a great time and we're saving people's lives every day. I do want to put in context of this that a lot of the ultrasound things I do is procedural or just for things like early pregnancy, to help people who have got anxious about things, DVT studies, not necessarily life-saving. But I do want to present this case because this really does raise a concept of whole body ultrasound to help diagnose conditions and also to exclude things that we worry about but have trouble excluding in a very efficient manner. So this was another case that I was involved with a couple of years ago, just before COVID, a fellow who had collapsed at his home in his caravan. He had definitely complained that he felt short of breath before he collapsed. He had some bystander CPR. His initial rhythm when the ambulance got there was pulseless electrical activity and CPR was continued. I might add as we go along, this person's collapse could equally occur anywhere in the healthcare system. It could be a deterioration on the ward. It could be after operation. There's all sorts of other places in the healthcare settings where this sort of thing could have unfolded. He didn't have IV access because it was so difficult. He had some adrenaline and a fluid bolus given through an interosseous needle. The extra history at the time was that he had paperwork in his house to say that he was going to have, or might have even had, a colonoscopy. That was unclear as to whether or not that had been happened. So a period of time in hospital, potentially immobile, was part of the presentation as well. As you can see, he was still unstable when he arrived in the emergency department. Now, this is another thing I've got a bit of an interest in. I'm certainly not the only person in the world. This concept of using multimodal whole body ultrasound of the heart, the lungs, the abdomen, the aorta, and even legs looking for evidence of DVT is increasingly an approach that ties in all sorts of applications to systematically look for contributing diagnoses or actually cross them off the list. So if we play this, I'll talk you through why. Right anterior lungs is being looked for and left anterior lungs to see if there's a pneumothorax. We'll play this more than once. It's a subcostal view of the heart and the IVC. Another subcostal short axis view of the heart, and we can see a sliver of something happening in the abdomen. That's lots of free fluid in the abdomen, a non-aneurysmal aorta, lots of free fluid around it, lots of free fluid in the right upper quadrant, and that's a big space of fluid around the liver, but that's normal lung at the right lung base. In the left upper quadrant, there's an enlarged, very abnormal looking spleen with a mixture of hyperechoic and even anechoic contents within it. More free fluid in the pelvis. So if we just play that again, the reason why we're doing this is because, of course, we're trying to worry about pneumothorax as a result of a collapse in CPR, and we've excluded that with those two images. Pericardial tamponade, we've seen examples of that before, that's off the list. Massive PE with a big right ventricle that's squashing the left ventricle, that's just been squashed off. This free fluid could be incidental. The aneurysm, there's no aneurysm or dissection of the aorta, but there's a lot of it in there. And so we're starting to wonder, could there be something in the abdomen that's caused bleeding to the point of hemodynamic collapse and continuing instability? And even though focused ultrasound is not supposed to be diagnostic of solid organs, you can say that that is a very abnormal spleen that looks like it's actually got some sort of hematoma in it, or maybe even some sort of continuing bleeding. And at the time that we were finishing off these images, we'd alerted the surgical team that we had somebody who we suspected actually had some sort of splenic injury, possibly related to them being in hospital having had their colonoscopy. They arrived, agreed, took one look at those pictures of the spleen and the free fluid and said, we'll get some O negative blood, we'll stabilise him on the way to theatre, we'll take the spleen out on the basis of these pictures. The ultrasound was also used to insert a 16-gauge femoral line for continued resuscitation, and we have some very rapid access kits to put in an arterial line. And that was all done in the time that it took for some blood to arrive and for the PSAs to be called to actually transport this guy to theatre. He had his spleen taken out. He was in ICU, HDU for about 24 hours and went home a couple of days later.
So thanks.
It's a bit of a blur, but you can see the power of, as long as it takes to describe those pictures, you actually have answers as to what is and is not happening with this patient.
Yeah. Now, you might argue that sooner or later you would have sent him to a CT scan. But that might have been quite a delay, and an unstable patient, a CT scan, we all know, is a really ugly thing. Yeah. And yet you could make that decision straight away. Yeah. You could work out, you may not have known the exact cause, but you knew there's a big lot of blood in the belly and that needed surgery. And that's brilliant. Thanks, Lindsay. A couple of other questions. Can any attendance certificates professional development be given? You've got the best one. You get a university testament. That's better than any certificate. It is a certificate. It'll do for what you need for professional development, because all the colleges are, we've gone through the process of accrediting with it. Are there any final questions before we close off tonight? Feel free to put your hand up if you, all right. Well, look, I hope that's been a fun hour for you guys, and thank you for coming and joining us. As I said, we still can take on enrolments. And so, but I wouldn't leave it too much longer if you are planning to do so. And feel free to contact us or Jazz to answer any more questions about what you do. One final thing I'm going to say, and this probably relates more to the, the student, to anaesthetists and intensive and gen med physicians. There's a real push to upskill in perioperative medicine. And we've very much believers that a significant part of perioperative management is to understand ultrasound. So we've developed a graduate diploma of perioperative medicine, which has the first 4 subjects as the graduate certificate of clinical ultrasound. So you can enroll, and then the second 4 subjects are much more sort of medically aligned to and surgically aligned to perioperative medicine topics. If you've done the grad cert, you can go straight on recognition of that to do the last 4 subjects of the grad diploma in perioperative medicine, or you can sign up from the start, but you'll do the first 4 subjects will be clinical ultrasound. So thank you again. Thank you, Lindsay. Great cases. I really enjoyed them. I never get sick of seeing that sort of thing. And thank you, Jazz, for organising the event. And maybe Jazz and Lindsay, if you can stay on, we'll say good night to everyone else. Thanks for coming.